Hello, and welcome to today's Lunch and Learn, Medical Weight Loss, Explore the Benefits. I'm Dr. Steve Reinches, the President and CEO of North Kansas City Hospital and Meritas Health. Thank you for joining us. Losing weight on your own is not easy. Trust me, it can be frustrating when results come slowly. With Dr. Breann Kelley, our expert speaker today, you'll have another option, medical weight loss. She is a medical weight loss doctor with our Total Weight Loss Center. Dr. Kelley will discuss how she partners with patients to create a customized, non-surgical treatment plan, one that meets the specific needs and achieves weight loss goals. Dr. Kelley is board certified in internal medicine, on the board of the Midwest Obesity Society, and a diplomat of the American Board of Obesity Medicine. She received her medical degree from the University of Missouri, Kansas City, where she completed her residency in internal medicine. If you have questions about medical weight loss, submit your questions using the Q&A feature below. We will get to those at the end. Please join me in welcoming Dr. Kelley.
Thank you. All right, I'm going to talk about medical weight loss. The first thing I'm going to start with is the criteria for excess body fat. This uses good old BMI, which is honestly one of my least favorite measures of excess body fat, but it's the one the insurance companies love, so we use it a lot. People I am typically working with are having a BMI of 25 and higher, so falling in that overweight range all the way to class 3 obesity. This is probably a little bit more accurate measure. It uses body fat. Waist circumference is another one that's more accurate, and that'll be touched on in a later slide. But you can see for women, it ranges from 14% for athletes to 31% at the upper end of ideal, and for men, 6% to 24%. And so again, most often the patients I'm treating are greater than 32% in women and greater than 25% in men. This I'm not going to spend a lot of time on. I'm just pointing out that excess body fat can affect pretty much every other body system, from cardiovascular, endocrine, cancer, all of this is affected. The other thing I want to make sure people understand is this is a big problem. More of us struggle with weight than don't. 65.2% of Missouri adults were overweight, and 30.5% had obesity, giving us a ranking of 10 out of 42, with 1 being the state having the most problem with obesity and 42 being the least. And this was actually 2012 data, so 10 years later, the problem is almost certainly worse. How much weight loss is needed? It's a question that's going to have a different answer for different people. But at 5% weight loss, we start seeing improvement in blood pressure, blood sugar, and cholesterol. At 10%, we start to see improvement in pretty much every other weight-related health condition, including sleep apnea, acid reflux, fatty liver, risk of several types of cancer. This I've put in to talk about how much weight loss you can expect with various treatments. The bottom 3 are the ones I'm working with. So that 2 to 5% lifestyle modification, that's typically things people are doing on their own. That prescriptive nutritional interventions, that's what I'm doing. That's much more intensive dietary changes. And then pharmacotherapy, we can get 10 to 20%. These are all additive. So I can pretty reliably get 10, 20, 25, sometimes even 30% weight loss. People who are wanting to lose half their body weight, they're almost certainly going to require surgery plus some of those other tools. Medical weight loss, most simply defined as non-surgical weight loss. We have 4 basic components: nutrition, exercise, behavior modification, and medication. And I'm going to hit each of those in a little bit more detail. The big thing I want everyone to understand is it's not eat less, exercise more. Eat less, exercise more is based on the theory that all calories are equal, and they're not. We know that M&Ms and spinach do very different things when they get inside of us. The other thing is hormones play a huge role. Of the hormones that control our hunger, satiety, fat storage, fat distribution, most of them are hunger hormones, and only a few of them are satiety hormones. We are very much designed to survive famine. The gut microbiome plays a role. That's the bacteria that normally live in our gut. There's studies on this. You can take gut bacteria from a naturally thin person and transplant it into a naturally heavier person, and that person will immediately start losing weight, and vice versa. Environment, if you don't have access to food, if you live in a part of city that only has, quick trip and fast food, it's going to be hard for you. If you don't live in a place where you can safely exercise. And then, of course, genetics. If your ancestors survived famine, you are much more likely to be able to survive famine. Insulin resistance, I'm going to talk about this one a lot. This is a big part of my job. Insulin resistance makes weight loss even harder than it already is. These are some of the measures I look at to see if someone is struggling with insulin resistance. The metabolic syndrome, which I'll talk about in a second. Looking at blood work, triglyceride to HDL ratio. If it's elevated, that gives me an idea. And then the HOMA-IR, we use fasting insulin and glucose levels. And basically it's a mathematic formula we use, and it calculates a number. If that number is over 2, that's consistent with insulin resistance. I actually don't get to use that one as much as I want because fasting insulin levels are not well covered by insurance, and I don't like to stick people with a big bill. Metabolic syndrome. You get the diagnosis with any 3 of those. So waist circumference, men over 40 inches, women over 35 inches, fasting triglycerides 150 or higher, blood pressure or high blood pressure or treated high blood pressure like hypertension, and then a low HDL cholesterol or good cholesterol, and then fasting sugar over 100 or known prediabetes or diabetes. The metabolic syndrome is important because it leads to all sorts of other big problems: type 2 diabetes, atherosclerotic cardiovascular disease, chronic kidney disease. And those things are some big healthcare expenditures for our country right now. So back to insulin resistance. It can be normal, such as in puberty, and there's my pubescent sons. Pregnancy is why we have to do glucose screening tests in pregnancy, acute illness, aging. And then it can also be abnormal, prolonged stress responses, sleep deprivation, prolonged sitting, which a lot of us have with our employment. A lot of us sit for work, excessive calorie load, and then increase in visceral fat or belly fat. Diet. So these are the definitions from Webster's. This is just strictly what diet means. Most of us think of number 3 and 4, and that's mostly what I'm talking about here. The kind of food we're using for a special reason or to eat sparingly to reduce weight. The best diet, the short answer, the one you can stick with long term. The longer answer is probably low carb. This is a compilation of randomized controlled trials comparing low fat to low carb diets. And basically the body of evidence there surpasses that what you need for phase 3 clinical requirements for approval of a new drug. So what I'm saying is, if a low carb diet was a drug, it would be FDA approved. Exercise is not super helpful for weight loss. It's really way more helpful for weight maintenance and general health. And for that, we need 2.5 hours a week, 150 minutes a week. For weight loss, if you're not going to change your nutrition or anything else, you need closer to 5 hours a week, unless you're a postmenopausal woman. And then you probably need closer to 7 hours a week. That's hard to do if you're working full time. So I recommend getting people to the 2.5 hour a week mark, but 10 minutes is where we start, because 10 minutes is where we start seeing health benefits from exercise. And so that's typically where I have people start 10 minutes. Behavior modification. Sleep is big. It's important. Without enough sleep, it affects everything, including your hunger hormones. Insufficient sleep increases hunger hormones. It decreases full hormones. Those hormones are not interested in salmon and broccoli. They want chips and M&Ms. Treating sleep apnea, same reason as getting enough sleep. Sleep hygiene is something I talk about a lot, and those are ways to improve sleep. Way too much to go into here. That could probably be its own 30-minute talk. Stress management, I recommend therapy, yoga, meditation, religious services, talking to your priest or pastor, spending time with friends and family, whatever works for you, do it. And I can help people kind of figure out what's best for them. Planning, obviously meal planning, but also pessimistic optimism. And what I mean by that is having the optimism, knowing you can do it, but the pessimistic part comes in anticipating those roadblocks, knowing all of the things that are going to jump up and make you stumble, and making backup plans for those. The quick reset. Everybody gets off track. Getting back on track is super important. If you're carrying your eggs in from the grocery store and drop one, you don't throw the other 11 away. Same with your nutrition plan. If you get off track, you don't throw the rest of the week away. You get back on track immediately. And then the daily habits, those are from the National Weight Control Registry, which is out of the University of Colorado. And they are keeping track of people who have lost a significant amount of weight and kept it off for several years. So we know that those people are eating higher protein breakfasts. They're monitoring their weight frequently. They're often still tracking their nutrition and regularly exercising. Medications. This is where I'm going to spend most of the time, because this is, I think, where most people are interested. When I use medications, I will change weight positive medications to weight neutral or weight negative medications if possible. I try and minimize the doses, types, or amounts of weight positive medications if possible. And sometimes, oftentimes, I will add medications that promote weight loss. This is not an all-inclusive list, but these are some medications that can most certainly promote weight gain. A lot of things on there for mood, for pain, such as gabapentin under seizures, but it's also often used for pain. Several for diabetes, although the newer diabetes medications are really great for helping with weight loss. And then, of course, good old prednisone. Medications for weight loss. I feel pretty passionate about this one. First of all, it's not just phentermine. This is a great time to be doing what I do. There is wonderful medications available now, and there's one on the horizon for this summer that I think is going to compete with surgery. Only 2% of candidates for anti-obesity medication receive prescriptions. And as we talked about, 5 to 10% weight loss improves weight-related conditions. And almost 2/3 of our state struggles with excess weight. So just by treating more of the people that are potentially candidates, we could really reduce healthcare costs. But unfortunately, most of these meds aren't covered. These are medications I use for weight loss. On the left side, you'll see phentermine and its cousins, which are approved for short-term use. In the middle, some that are approved for longer-term use. And then on the right side are medications that are not FDA approved for weight loss. They're approved for other conditions, but they can help with weight loss. And so in the right people, we do certainly use them. So going into the medications themselves. Phentermine is the oldest medication for weight loss out there. It's been around since 1959. Phendimetrazine, daltepropion, and bensphetamines are its cousins. They all work similarly. They decrease appetite. They can increase your resting metabolism because they increase heart rate, blood pressure, core body temperature. They're approved for obesity, so a BMI of 30 or higher, or overweight with a BMI of 27 or higher, as long as you have risk factors such as high cholesterol, diabetes, that sort of stuff. They're approved for short-term use, so typically about 3 months. Like all medications, it has contraindications, and those are listed out. It is a controlled substance, so it does require frequent check-ins. Orlistat is over-the-counter as Ally. It's a prescription as Xenical. It is approved for a BMI of 25 or higher. It's approved for long-term use, meaning weight loss and weight maintenance. It basically blocks the absorption of fat in the gut, which can cause a laxative type effect. I actually don't use this one very often unless people are constipated. Then as a laxative, bonus weight loss. And again, those are the contraindications. Fusimia or Fusimia, I've heard it pronounced both ways, is phentermine, typically at a lower dose with an extended release topiramate. Topiramate is a medication we use for migraine headache prevention and for seizures. It has been studied for binge eating disorder and does appear to be effective for it, but does not have an FDA indication for that. Same as the prior medication approved for BMI of 30 or higher or 27 or higher with risk factors. And again, long-term use, so it can be used for weight loss and weight maintenance. The contraindications are similar to what you would see for phentermine, but it's also important to know that topiramate can cause birth defects. So women of childbearing age, I would steer them away from this one. It can also increase your risk of certain types of kidney stones, and we cannot use it with glaucoma. Contraves is another combination of two medications. Bupropion is Wellbutrin for as an antidepressant. It on its own can help a little bit with weight loss. It also helps with quitting smoking. We add naltrexone to it, we do get more weight loss. We also get more nausea, dizziness, headaches. Slow titration can really help with that. The naltrexone portion blocks opiate receptors, so we can't use it in people who require chronic opiates. And I will take people off of it 5 to 15 days before surgery where I know they're going to need opiates. But it works in the brain, helps with appetite regulation and cravings. And we cannot use it in people with seizure disorder as well because of actually the bupropion portion. It can decrease the seizure threshold. So for people who are prone to those, it can make it easier for them to have a seizure. Liraglutide. This is an interesting one. It's Victoza for diabetes. It is Saxenda for weight loss. It is the same drug produced by the same company under 2 brand names. GLP-1 agonist is its class of medication. GLP-1 is one of our full hormones. So this medication looks like our full hormone and it helps us feel full. It also improves insulin sensitivity. Helps with cholesterol, decreases risk of cardiovascular events in patients with type 2 diabetes. And those are its contraindications. You'll notice all of these have a contraindication of pregnancy. We do not use weight loss medications in pregnant women. Semaglutide is a cousin of liraglutide. It is Ozempic for type 2 diabetes and Wegovy for weight loss. So same hormone mechanism. Wegovy has been kind of a mess. There is a worldwide shortage of it. So we actually are not able to start new patients on it right now, which is a bummer because it has been really, really effective. It's probably the most effective medication on the market right now. Same contraindications as liraglutide. Vyvanse is actually not approved for weight loss. It is approved for ADHD and moderate to severe binge eating disorder. I would like to note it is not the only medication that has been studied and is effective for binge eating disorder. It is the only medication FDA approved for that. It's a stimulant. It's actually a C2 or a very tightly controlled substance, so it really requires frequent check-ins. Gelesis 100, or under the brand name Plenity, is actually approved as a device for weight loss for a BMI of 25 and higher with no length of use restriction. So you can use it for weight loss and weight maintenance. The reason it's a device is it's not absorbed systemically, so it's not changing your body chemistry. Safety profile is similar to placebo, and actually I think they had more people quit their placebo group than their treatment group. You take 3 capsules of cellulose and citric acid, which are plant fibers, with at least 16 ounces of water, at least 20 minutes before lunch and dinner. Those plant fibers mix with water, they turn into a gel, the gel expands, it helps you feel full. Side effects are similar to placebo and exactly what you would expect: bloating, heartburn, change in stools. The contraindications, they have kind of loosened up on this, especially in regards to prior bowel surgery. I will tell you, I will not use this device in patients who have had weight loss surgery because I do not want to risk stretching out their pouch. Metformin. So 3 reasons I love metformin. Number 1, it helps with insulin resistance. It treats the underlying issue. Number 2, it's carbohydrate truth serum. So it blocks some of the absorption of sugar in the intestine. So if you overeat that stuff, it's going to give you GI side effects, mainly diarrhea. It helps us make better choices. That cupcake's not worth it anymore. Now we're going for an apple for that sugar craving. And number 3, it's cheap. It's on the $4 list at Walmart. So if you do hate it, it's not a huge financial loss. This I put in to show you kind of what to expect, especially longer term. 5 to 10% is clinically significant. 15 to 20% is where you're really going to see a reduction in those weight-related conditions, especially like reversal of type 2 diabetes is that 15 to 20%. And so 10 years out, you can see surgery is beating everything else, hands down, even top dose semaglutide, which is Wegovy. So in summary, weight loss is hard. Weight maintenance is even harder, but science can help. The deck is stacked against us. We are really designed to survive scarcity. It's not in your head. It really is easier to gain weight than to lose it. Failure of willpower is almost never the issue. It's usually hormones and medications and environment. There's so many other things at play. And finally, you probably need to lose less weight than you think to start seeing improvements in health. That's it.
So I get the opportunity to do these lunch and learns with all sorts of doctors and all sorts of specialties. I want to tell you, this was one of the most fascinating ones I've been to. I'm hoping that the listeners enjoyed it as much as I did. We do have some questions from the audience, if you'd take a few.
Sure.
And I have some questions in my own head I might throw at you.
Okay.
So here's one from the audience. What are the most difficult challenges you found for patients who stumble in their program?
There is no universal answer to that. There's really not. I've seen everything. It can be trouble getting medications covered. It can be life stress. Life stress is a big one. It derails the best of us. And so that one is really a case by case. There's no universal thing.
It's not lost on anyone that the pandemic has been extraordinarily stressful on society.
Really good for my business.
Yeah, I can imagine. So the questions are just coming in quick from the audience. Does insurance cover non-surgical weight loss options? That
depends on the insurance. They don't typically cover medications. They may or may not cover my visits. I think we're having pretty good luck getting my visits covered. My guess is more than 3/4 of the time.
Another listener really liked the presentation, and she wanted to know if the slides would be available for review later.
Yes, I'm told yes.
Can I just one comment? I really like your logo, the total weight loss. I really like the color and the shape, and I just love that.
That's not me, but thank you. I like it too.
Yeah. Can you give us a few examples of what a high protein breakfast is?
So my personal go-to, because I am actually not super hungry usually in the mornings, but I know I need that high protein to keep me on track the rest of the day, is I often will do a Premier protein shake and I will mix it in my coffee like a coffee creamer. But some of my other favorites, eggs. The 000 Greek yogurt from Oikos has a decent amount of protein in it. Cottage cheese.
Really?
Mhm.
What about protein bars?
You have to watch the sugar.
Mhm.
Some of them are definitely better than others.
They're just easy to pick up.
Yeah.
Another question, do people have more success with weight loss surgery or a medical weight management program?
So it depends on what you mean by success. If you mean maintenance of weight loss, surgery wins every time.
Mhm.
I mean, even when you count in people who regain every single ounce after surgery, you add them into your total, you average amount, weight loss surgery is still the most effective tool in the toolbox.
Okay. Here's another listener said that they have lost weight several times, but they always gain it back. How is your program of medical weight loss going to be successful for them?
Well, there's no guarantees, but my hope is that we can teach you the tools to help you get yourself back on track before you slip and regain everything. Also, hopefully we can find some medication changes that we can make that will help promote weight loss rather than weight gain.
Another audience member said, is it beneficial to work with a dietitian while doing medical weight loss?
I would say yes. I'm also biased. I think the 4 we have in the Total Weight Loss Center are the best. And so I will, even when people say I have met with a dietitian somewhere else, I make them then meet with mine.
Yeah, I think a coordinated program is great. Here's another comment from a listener. Great presentation. And this person says, I have willpower until bedtime and then often raid the refrigerator and can double the amount of calories I've had for the day. Do you have any recommendations for keeping up the willpower when the stress of the day is gone and it's time to relax?
Yes. So one, make sure you're getting enough protein during the day with breakfast and lunch. A lot of times, if we're not getting enough protein early in the day, that's when we start overeating in the evening. The other thing is, if it's stress or boredom, doing something else to take care of that stress or boredom, going for a walk, doing a crossword puzzle, calling a friend, that sort of stuff. Distraction works really well.
Yeah. So this just came in. I'm going to read it verbatim. I've heard you're the best of the best. Can't wait until my appointment with you. Do you have a comment on that?
I think that's awesome. I can't wait to.
Here's another person. Can you give a good example of protein for lunch?
Meat and veggies. That's always my go-to. So I always grab some sort of meat. And that can be whatever you like. Chicken, fish, turkey, beef.
So I have a question. This one's for me. So I spent most of my days as a surgeon. And when you're doing surgery, there's no breaks. And so there'd be long periods of time where you wouldn't eat. And then when you would break for a meal, like dinner, you would maybe go overboard. There's been a new diet fad called intermittent fasting, where you go 18 hours without eating, and then you have a 6-hour window to eat. For a guy like me, that's a pretty easy thing to do. What's your opinion about intermittent fasting?
I think intermittent fasting can work in the right person. This is anecdotal, but I've noticed that women struggle with intermittent fasting. It seems to be a better fit for men for the most part. The other thing is you got to remember when you do eat, you've got to get that protein in first. You've got to. It didn't work for me. When I tried intermittent fasting, there was some part of my reptile brain that remembered every calorie I didn't eat and wanted it and its first cousin when I did break the fast. So I really do better getting that protein, breakfast, lunch, dinner. That helps keep me on track.
And you consciously start your meal with the protein
Absolutely.
to get that satiety?
Yes, satiety is part of it. Also, protein takes more calories to break down than other macronutrients, the thermal effect of food. So its thermal effect is almost double what other macronutrients. So it actually helps you raise your metabolism a little bit. It also is super important for protecting lean muscle mass, which is important to protect your resting metabolic rate as you lose weight.
Great. Thank you. Here's somebody else. Dr. Kelley is awesome. Everyone in that group is great. I'm currently working with her, but wanted to attend to pick up more tips. You're getting a lot of kudos today. Here's another one. Does menopause play a role in weight gain? If so, how?
Yes. Mostly the aging. As we age, and especially at menopause, we become more insulin resistant. And so that's the big thing, is the insulin resistance. And so that's an area in life where starting to cut back on carbs, especially processed carbs, is going to be really helpful for weight maintenance and weight loss.
So here's another question. My doctor doesn't address my weight. Do you have suggestions for starting that conversation with him and bringing up medications?
I think you just do that, exactly that. Say, I want to talk about my weight. I want to talk about options for weight loss as far as medications. I think a lot of doctors avoid talking about it because they don't want to offend people. And so I imagine a lot of them would actually be relieved to have it brought up.
When I was operating, I had a certain threshold that if a patient weighed more than a certain amount, I wouldn't operate on them because their surgical outcome was so poor. And when I got to that discussion about their weight, I will tell you, as a treating physician, many people were offended. Here's one last question. Do you recommend any online resources to complement a weight management program?
So I like nutrition tracking software, and a lot of that's online or on a smartphone. And the Total Weight Loss Center, we use the Berrytastic app, but I also really like Carb Manager. I've seen a lot of success with MyFitnessPal. The Apple Health app can be helpful. Anything that helps keep you on track with your nutrition, keeps you on track with your exercise, I think can be helpful.
Okay, I said that was the last question, but I have one more comment from one more attendee. And this is a quote. I've lost 25 since I saw Dr. Kelley in January.
Yay.
That's a win. That's a big win.
That's a big win.
That's a big win.
That's clinically significant.
Yeah. Well, I want to thank Dr. Kelley for her presentation today. It was fascinating for me and certainly from the audience. As you've heard, obesity isn't as simple as eating too much. It's a complex health issue influenced by a combination of factors, including behavior, genetics, and environment. We hope Dr. Kelley's presentation was informative and helpful. The good news is there are many things you can do. Find out more at totalweightloss.com. That's one word, totalweightloss.com. Please join us Tuesday, May 24th for our next Lunch and Learn, Shoulder Pain, Don't Shrug It Off, with Dr. Craig Satterley, an orthopedic surgeon at North Kansas City Hospital, and with Orthopedic Health of Kansas City. Again, thank you for joining us and have a good afternoon.